Okay, so the next presentation is Dr. Moussa from MGA. She's going to talk about post-procedural LAA occlusion leak mechanism, implication, and treatment. Good day, everyone. It is great to be here. I would like to thank Doctors Lakiredi, Natale, Holmes, and Carr for inviting me. I'm going to talk about post-procedural left atrial appendage exclusion leak. So this whole lecture is about Plan B. As you know, very little is known in this area, and my goal today is to bring some clarity to the subject. So to do that, I'm going to talk about the following aspects of incomplete closure of the left atrial appendage. And these are the mechanism of incomplete closure, the prevalence, implications, and managements. We'll start with the mechanism, and the mechanism of incomplete closure depends on the type of the device or the technique used. So it is different for endocardial devices compared to the epicardial device, compared to surgical closure. And we'll talk about each of them in the next few slides. We'll start with endocardial devices, and in most cases, the mechanism of incomplete closure and with endocardial devices is due to a mismatch between the anatomy of the left atrial appendage and the shape of the device. Most devices, all devices used for endocardial closure are circular, and we know that the left atrial appendage ostium is oval. So this mismatch leads to leaks around the device. And the other anatomical factors. These are two patients with different shapes of the left atrial appendage ostium. The one on the left is a circular ostium, and if you put a circular device, you can expect a closure here. The patient on the right here, the appendage is elongated and oval, and a circular device may not be able to occlude the whole appendage, and you may be left with a leak on either side of the device. Here's an example of incomplete closure after a Watchman device, and you can see this is a typical size and location of a leak at the edge of the device, probably due to a mismatch between the circular device and an oval appendage. This is an example of how a multilobar appendage with early bifurcation can lead to incomplete closure. This is a patient with 3 lobes in the appendage. Initially, we thought that the patient had only 2. There's an anterior one, there's a pigtail in it, there's a pigtail in the posterior lobe. When we placed the Watchman device, there was a gap on this side, and once we knew what we're dealing with, we placed a larger device and placed it more proximally to be able to occlude all the lobes. So initially, probably this device was stuck in one of these lobes, preventing it from opening and fully and closing the whole appendage. The mechanism of incomplete closure with lariat epicardial device is illustrated in this slide. This is in a dog after closure, and you can see the central portion where all the tissue is crunched together. This is probably where the leaks occur with this device. So you have all the tissue that's been squeezed together in the center. Here's a TEE showing a leak with lariat device, and you see it over here. So the leak with this device is central compared to the Watchman device where it is at the edge of the device. The mechanism of incomplete closure with surgical ligation is a little bit more complicated, and it may be due to a couple of reasons. After surgical excision, there may be a residual stump. The stump, it's by definition, if it is more than 1 centimeter, the procedure is defined as non-successful or non-closure. If the appendage is not excised, if it is sutured, the leak is usually towards the edges of the left atrial appendage, where the running suture may not start at each of the ends of the appendage. And this can happen because when the surgeons do the procedure, the appendage is, the heart is not full of blood and the appendage is empty, and this may exacerbate this phenomenon. Also, if the sutures placed are not, if they are shallow, if they are not deep, because of concerns or of hitting the circumflex artery, they can lead to dehiscence and the occurrence of leaks. This is an example of incomplete closure with surgical ligation, and as I just mentioned, the leak is usually towards the end of the appendage, which we see over here. So we talked about the mechanism. Let's see how prevalent this is. And again, the prevalence depends on the type of technique and the type of device used. This is the prevalence of incomplete closure with the Plato device. In this table, this is a description by TEE, different types of leak: severe leak, moderate, mild, trace, and no leak. These are the TEE percentages at 1 month and 6 months. And no leak occurred in 18% of the patients. So the rest of the patients had one type or another of some incomplete closure. No severe, there were no severe closures, no severe incomplete closures. So 0% severe and 0% moderate. The most complete data about incomplete closure came from this recent publication by Vivek Reddy and colleagues from the Protect AFib study regarding the use of the Watchman device. This is the description by TEE, whether there was closure or not, and 45 days, 6 months, and 1 year TEEs. And here are the percentages of complete closure, so no leak at all, 53% at 45 days and 64% in 1 year. When a leak was present, here are the measurements. So the average size of a leak was 2.9 millimeters, ranging between 1.1 to 6 millimeters. When a leak is present, here are the distributions. Most leaks were between 1 and 3 millimeters. About 30% were more than 3 millimeters. We'll move now to the epicardial device or the Larial device. This is from a publication from Dr. Bartos and Dr. Lee. This is the initial experience with this device, 85 patients, and here are the rates of closure. Complete closure in this study was defined as either complete or the presence of less than 1 millimeter leak. And here are the percentages. So in general, over 96% of all the patients had either complete or less than 1 millimeter leak. In this manuscript, there was no differentiation between complete or less than 1 millimeter. They were lumped together. So it wasn't clear how many of the patients had complete and how many had less than 1 millimeter. So we looked at our own data together with Dr. Reddy. We looked at 55 patients who were considered complete closure, meaning less than 1 millimeter and complete. And we found that among these patients, 11% had less than 1 millimeter, but 89% of the patients had no leaks at all. This is the prevalence of leaks with surgical closure. These are the types of surgical closure: excision, suture exclusion, and stapler exclusion. These are the percentages of successful closure. It is best with excision. The rate is 73%, drops to 23% with suture exclusion, and 0% with stapler exclusion. So all patients in this study who were closed with a stapler exclusion had some kind of communication with the left atrial appendage, between the appendage and the atrium. In this study from the Cleveland Clinic, looking at the residual flow with the surgical clip, which is a new device for closure, there were no leaks. They had complete closures in all patients. So what does this all mean? So we talk about how it happens. I discussed with you about its prevalence. So let's see what it means to have some kind of communications between the atrium and the appendage after these procedures. This is from the same publication I mentioned earlier by Dr. Reddy, and the data is from the Protect AFib study, looking at comparing the primary efficacy endpoint by leak severity. So these different categories are, the dark blue is for primary efficacy of this study, which was a combined endpoint of stroke, cardiovascular and unexplained death, and systemic thromboembolism, all lumped in the primary efficacy endpoint. Ischemic stroke in lighter blue, ischemic stroke and systemic embolization in the lighter color. And these are the leak categories: less than 1 millimeter, 1 to 3, more than 3, and none. This is the event rates, and as you can see, there were no significant difference in the event rates among all these categories. This is a slightly different way of presenting the same data. This is efficacy, primary efficacy endpoint, and this is the systemic stroke and systemic embolization, any flow or no flow at all, and there were no significance in primary efficacy endpoint and stroke and embolization, whether you have flow or not. This is for surgical. These are the implications after surgical ligation. The presence of left atrial thrombus was found to be in 41% after unsuccessful occlusion. There was none with excision. Even when the stump was larger than 1 centimeter, they did not find any thrombus in these appendages. When they looked at stroke and TIAs, there was no difference between the two groups, whether you have successful closure or unsuccessful closure. There were no difference in stroke and TIA. So there was a higher prevalence of thrombi, but there were not, the clinical events were the same. This has to be taken with caution, however, because the number of events were very small in this study. So what to do about it? Here are the things that this can be managed with. So one is closing the leak. There is no data on this. There are a couple of cases that Dr. Carr had closed. We heard about one earlier where he closed the leak with a coil or some other devices, but this is not performed on a wider, larger scale. The most important in this is prevention, and the third important thing that you have to consider when dealing with a leak is the decision about stopping anticoagulation. You know, again, unfortunately, the data is very limited, and I will show you what I came across in the next few slides. So for prevention, it is important to avoid unsuitable anatomy and consider another device or technique. Some anatomies may be suited best for a Watchman device, other for a plug, others for an epicardial device. So it's important to customize each patient with the device that suits him or her best. A larger device and a more proximal position for endocardial devices may help in patients with early bifurcation. For epicardial closure devices, we avoid the use of steroids because they prevent the inflammation and they may delay healing or closure of the appendage. The decision about discontinuation on Coumadin, the best or the most complete set of data in this field is from the Protect AFib study. Here are the primary efficacy event rates according to the presence of peri-device flow and warfarin use. These are 4 categories, 4 groups of patients. No flow, Coumadin was stopped. No flow, patient continued on Coumadin. Any flow, discontinuation of Coumadin. Any flow and continuation on Coumadin. And there was no significant difference between these different groups. So again, this should be taken with caution because the event rates in the study were very small as well. So over the course of this lecture, we talked about the prevalence of leaks, their mechanisms, their implications, and management. And I would like to summarize with the following. Incomplete closure is common with the currently available devices and techniques for left atrial appendage closure. The mechanism of incomplete closure depends on the device and techniques used. Limited data from surgical studies suggest that incomplete closure is associated with increased left atrial appendage thrombus, but no thromboembolic events. Again, the number of patients were very small in these studies. Data from the PROTECT AFib study showed that no relationship between incomplete closure and thromboembolic events. And overall, the data in this field is limited regarding the discontinuation of anticoagulants with incomplete closure with most devices and techniques. And thank you for your attention.